Welcome to This Explainer. We're going to take a deep dive into an organism that's really moving from the background into the spotlight, Parvimonas micra. For years, it was a name many of us in the lab just saw every now and then. But with all the new diagnostic tech, we're finally starting to see its true and often pretty serious role in human disease. So we've got to start with a question that really gets to the core of what this thing is. Is Parvimonas micra just a harmless bug hanging around? One that only causes trouble when the conditions are just right? Or is it something more, like a signal flare, pointing to a much deeper problem? How we answer that really changes everything about what we do when we find it in a culture. To get us all on the same page, let's use the term that just perfectly describes Parvimonas micra, a pathobiont. It usually lives peacefully on mucosal surfaces. But the moment a host's defenses are down or the local environment gets thrown off balance, it grabs that chance to become a real pathogen. And that brings us to a really key idea. We're not actually seeing a new emerging pathogen here. Nope, this is a pathogen that was there all along, hiding in plain sight. We're only now uncovering it because of these huge leaps forward in our diagnostic technology. The best way to understand how it causes disease is through this idea of the oral systemic access. Just think of the mouth, especially when there's poor dental health or periodontitis, as its primary base of operations. From there, Parvimonas micra can slip into the bloodstream and set up shop, causing serious, deep-seated infections in places far away from the mouth. And this doesn't just happen to anyone. As a classic opportunist, Parvimonas micra is looking for a weak spot. We see it causing really invasive disease in patients who are immunocompromised, or those who have had procedures that break down mucosal barriers, or even in patients who have things like prosthetic joints and heart valves. Okay, so this brings us to identification. The evolution in how we detect this bug is, without a doubt, the single biggest reason we're seeing it pop up in so many clinical reports lately. We've gone from these slow, really challenging culture methods to being able to identify it rapidly with molecular tools. And check this out. This timeline really shows what a major challenge this has been. This organism has had a serious taxonomic identity crisis. For decades, it was known as Streptococcus micra. And this is so important. If you're only searching the literature for Parvimonas micra, you are going to miss a massive amount of crucial historical data on this bug.
This slide just captures the before and after perfectly. Traditionally, it was a nightmare in the lab. A slow-growing anaerobe, a gram stain that was all over the place, and it was so biochemically boring that our commercial panels were basically useless. But today, MALDI-TOF gives us a rapid, accurate ID in minutes, and sequencing methods like 16S and metagenomics can find it even when it won't grow. That is the game changer.
All right, for all of us at the bench, this table here has the essentials. Remember, it's a tiny gram-positive coccus that just loves to decolorize so it can look gram-variable. It's a strict anaerobe, so it's slow to grow. And when it finally does show up, you're looking for those small, glistening colonies, sometimes with that telltale yellow-brown halo on blood agar. Okay, so let's move from what it looks like on the plate to what it's actually doing to the patient. Let's look at the huge range of diseases this organism can cause. And wow, as you can see, the list is long. It starts out in its home base in head and neck infections, but it has a real knack for getting into bone and joints, causing things like spondylodiscitis, which is notoriously hard to treat. It can also cause devastating infective endocarditis, deep organ abscesses, and has even been linked to the microenvironment of colorectal cancer. Now, this is the most important point. When your lab finds Parvimonas micra somewhere it shouldn't be, like in blood or a deep abscess, it has to be treated as a major event. This isn't just about giving the infection a name. It is a giant clue telling clinicians they need to start searching for an underlying problem, maybe an undiagnosed dental abscess or diverticulitis or even a malignancy. So now that we can find it more easily, the big question is, how do we treat it? And this is where it gets a bit complicated. We don't have specific guidelines just for Parvimonas micra, and we're starting to see some really concerning trends in antimicrobial resistance. Just look at this chart. This is the biggest therapeutic challenge we're facing right now. A major U.S. study found that in just 10 years, clindamycin resistance in Parvimonas micra shot up from 2% to almost 50%. The takeaway here is crystal clear. In many parts of the world, you just can't trust clindamycin as an empiric choice anymore. So what do we use instead? Well, the Dutch SWAB guidelines are a really useful model. They take a syndrome-based approach. For infections where anaerobes are a big concern, the treatment plans are built around drugs with solid anaerobic coverage, like amoxicillin clavulanate or maybe a cephalosporin paired with metronidazole. And you see this same pattern in other international guidelines from groups like ESCMID and IDSA. For the really severe infections, the recommendations rely on broad-spectrum combinations. And just look at the treatment times on this slide. For deep infections like spondylodiscitis or a brain abscess, we're talking about really long courses of therapy, often 4 to 8 weeks, sometimes even longer. What about for kids? Well, the principles are exactly the same, but the execution needs to be absolutely meticulous with weight-based dosing. It is so important to follow established pediatric formularies. For example, with amoxicillin clavulanate, you have to pay attention not just to the amoxicillin part, but also the clavulanate dose to avoid those nasty GI side effects. Okay, let's switch gears and talk about the lab's crucial role in antimicrobial susceptibility testing, or AST, and then we'll get into the bigger picture of prevention. Okay, this is a really critical piece of information for every clinical lab. As of early 2025, EUCAST has not yet published any official clinical breakpoints for Parvimonas micra. The organism is on the radar, it's part of a project, but for right now, we are operating in a bit of a gray zone when it comes to interpretation. So, what are we supposed to do in the meantime? Well, the official guidance from EUCAST is pretty clear, as you can see here. We should perform susceptibility testing, but we should only report the quantitative MIC value, the number, without calling it S, I, or R. This basically forces a much-needed conversation between the lab and the clinical team to figure out what that number means for their patient. Finally, how do we prevent these infections? Since they come from the patient's own flora, this isn't about isolation rooms. Prevention is really a 3-step process. First, for an active infection, aggressive source control is the absolute cornerstone. You have to drain the abscess. Second, the best primary prevention is to target the reservoir with good oral hygiene. And third, in the hospital, standard precautions are all you need. So let's circle back one last time to this powerful idea. Because if you remember anything from this, it should be this. Finding Parvimonas micra is not the end of the diagnostic journey. It is the beginning. Its presence is a demand that we look deeper for the hidden problem that allowed this quiet commensal to become a potential killer.
And that leaves us with a final question, a provocative one for our whole profession. In this age of MALDI-TOF and metagenomics, are we here just to put a name on a report? Or is our real value in helping interpret that finding in its clinical context and becoming active partners in finding our patients' hidden disease?
We really hope this explainer on Parvimonas micra was helpful. This entire report was put together using Gemini Deep Search. If you want to see a complete list of all the source materials, you can check out the notebook document that's linked in the description. Please go ahead and subscribe to the channel, and we would absolutely love to hear your thoughts and feedback in the comments below.